Thank you, Dr. Bach. Thank you, Dr. Dunne. This is Jeff Roberts, one of the partners. Happy to be Dr. Dunne's partner. And I just want to introduce her for her talk on elective egg freezing. Dr. Dunne is one of our co-directors at PCRM and also a clinical assistant professor within OBGYN at UBC. And she completed her medical school at University of Western Ontario and then moved out to BC for her residency in OBGYN at UBC, as well as her fellowship in reproductive endocrinology and infertility. Dr. Dunne's clinical interests are primarily, of course, with infertility, but also transgender care, LGBTQ fertility care, and she's really been at the forefront of egg freezing care in BC. Dr. Dunne also serves on the editorial board of the British Columbia Medical Journal, as well as the TELUS Community Board. And we're proud to say that she was also named one of Canada's top 40 under 40 in 2019. So Caitlin, could you give us the talk? Thanks. And if you could just share your screen, that'd be great.
All right. Thank you very much for that kind introduction, Dr. Roberts. I am going to talk about egg freezing. And I'll just make one disclosure that I do cite research on cisgender women, and I will use the word women and female, but that is not intended to exclude the conversation about transgender men and non-binary people from fertility preservation. So first of all, what are the definitions we're using here? When we talk about social egg freezing, we're talking about the cryopreservation of mature eggs on an elective basis for the purposes of delayed childbearing. And this is a little bit different than the umbrella term of fertility preservation, which can refer to freezing eggs or ovarian tissue or the whole ovary. And usually that's done before gonadotoxic treatments like chemotherapy or radiation. Now, egg freezing is relatively new. The first birth from a frozen egg happened in 1986, but back then the survival rates of eggs were very poor and pregnancy rates were even poorer. It was estimated that you needed about 100 eggs to achieve one live birth. Now, fortunately, since then, the technology has come a long way, stemming originally from a change in Italian law. And then it's come so far that in 2012, the American Society for Reproductive Medicine removed the experimental label off of egg freezing. And now you'll see it as mainstream for many companies, offering it as a perk to their employees. So why does egg freezing matter to you and to your patients? I'm sure I don't have to tell all of you in the community that women are choosing to have children later in life. We are all seeing this. Since 2010 in Canada was the first time where more women in their 30s were having children than women in their 20s. And since then, the trend has only grown. In 2020, BC had the highest mean age of mothers in the country at 32.1 years, just up from 31.9 in Ontario. And based on the latest available data from BC, you can see here that the vast majority of births are happening to women between the ages of 30 to 39 at 58%. Here's a little bit more local data. This was a survey study that was published in a very good journal, Fertility Sterility. They surveyed 360 female undergrads at UBC. And what these authors concluded was that although most women were aware that fertility declines with age, they significantly overestimated the chance of pregnancy across all ages, and they were not conscious of the steep rate of fertility decline. So taken together, I think we can interpret that women are waiting longer to have children, but there is a disconnect between what they want and what is biologically possible. And one author who writes about this has termed it sleepwalking into unintended childlessness. Now, many critics of egg freezing would say that companies are just paying for egg freezing so that they can keep their women in the workforce and increase their profits. But in fact, that is not true. There are many studies on this topic, and consistently, they find that the #1 reason that women are delaying childbearing is lack of a suitable partner. And that is followed distantly by other things like education, professional pursuits, financial reasons, etc. So when we talk about egg freezing, it's described as a potential bridge during the gap where a woman is in her reproductive prime and when she is realistically ready to have children. So when we counsel our patients, what can we tell them about the costs of waiting to have a family? There are 3 broad costs. The first one is infertility. The second one is miscarriage. And the third one is aneuploidy. And I'll share with you a little bit of data about why that's the case. Now, I just wanted to start this conversation by demonstrating the vast biological inequity between men and women when it comes to reproduction. Men make sperm in perpetuity. That means that they can reproduce probably for most of their lives, and they are constantly making new sperm every 70 days. So in our lab, they captured this video for me, and it shows that this has severe male factor infertility, very few, very slowly moving sperm, maybe, lots of dead sperm there. And even in cases like that, where we wash the sperm, we can often get hundreds of thousands or even millions of motile sperm that we can use in just one sample or one ejaculate. Now, contrast that against the female, where females have the maximum number of eggs they're ever going to have at 20 weeks gestation in the uterus. And by the time she's born, a female has about 1 million eggs. Now, this study, I like to cite this study. It's one of my favorites. It's based on necropsy specimens where they actually counted the eggs in females from birth through the lifespan. And we can see here that after being born with about 1 million eggs, there is a decline almost right away in the number of eggs. A very small proportion of those will actually ovulate. So about 500 eggs in the lifetime will ovulate. The vast majority of the eggs just die by atresia until the menopause threshold at about 1,000. And this is one more diagram from that study. And I just want to call your attention to 2 areas here. This is the 30 to 34-year-old age category, where there are still on average hundreds of thousands of eggs remaining. And in the very next category at 35 to 39, we're in the 30,000 or less. So there is a very steep decline in the number of eggs in the late 30s. One of the things we often hear in the fertility clinic is that menses are erroneously equated with fertility, when in fact, most women lose the ability to conceive at least 10 years before the cessation of menses. And we also hear, I'm young and I'm healthy and I do yoga and I eat vegan, so my fertility will last longer. And while those are very good things, we can't make our egg counts better. We can certainly make them worse with things like chemotherapy, radiation, smoking, things like that. But unfortunately, a healthy lifestyle does not make your ovarian reserve better. So I'll touch briefly on ovarian reserve testing, not to worry because Dr. Roberts is going to expand on this later this afternoon, but there are 3 main ovarian reserve tests, and I've listed them here on the screen. The first one is a day 3 FSH, which most of you would be familiar with ordering. We can see here that across all age groups, the red line on this graph being younger women under 35, and the blue line being older women over 43. When the FSH is above 7, fertility across the board starts to decline. And the way that I describe this to patients is that FSH is coming from your pituitary and it's going down to your ovaries and telling the ovaries to make eggs. So if the FSH is going up, it's like your brain is yelling at your ovaries. And that can be a sign that your egg numbers are running low. The second thing is an antral follicle count. This is not something that you will get on a standard outpatient ultrasound, but it's a 3D vaginal ultrasound look at the ovaries, and we scan the follicles in real time. If there are more follicles available, that would infer a better ovarian reserve. And this is something that us as fertility doctors would do on just about every single patient that we meet. And finally, anti-Mullerian hormone. Many of you probably familiar with this as well. Anti-Mullerian hormone is produced by the granulosa cells. And in this picture, that's these purple cells here in the small antral and preantral follicles. So that would be the constant supply of follicles that are available. And then once the follicle gets large, as you can see here, it stops making AMH. So that's why AMH is constant throughout the cycle, and it's valid on any day. So it's a very convenient test to order. AMH is most commonly useful for IVF dosing and for us in fertility clinics. Sometimes gynecologists will order it pre and post surgery to see how much of an insult the ovaries took, say, for example, after a cystectomy. Anybody can order it. It costs $70 in British Columbia. In Alberta, it's covered by the medical services plan. The normals are highly age specific, so it can be a little bit tricky to interpret, but across the board, anything less than 8 picomolars is low. And on the other end of the spectrum, a high AMH is not diagnostic of PCOS, but of course it can be helpful if you're seeing somebody with irregular cycles and you're wondering, is this perimenopause or is this PCOS? The AMH can help you make that differentiation without even having to get an ultrasound. Now, we've just talked about how the quantity of eggs declines over time. We're also going to talk about the quality of the eggs. Now, because women are born with all of their eggs, as they get older, they become more prone to making mistakes. And that would be like aneuploidy or having the wrong or incorrect number of chromosomes in the embryo. This is probably because of changes over time to things like the meiotic spindle, mitochondria, and cohesins. What we know is that eggs are never perfect. So I always reassure my patients that even women in their 20s can have miscarriages. And what you can see on this slide is that even 20% of the conceptions that happen to women in their 20s can be aneuploid. So unfortunately, miscarriage is common. But once you get to age 40 or 45, you can see that the majority of conceptions at that point would be aneuploid. And the reason for this is because in meiosis 1 and meiosis 2, the division of chromosomes can happen incorrectly. So I'll just take you through this diagram. Starting here, when the egg ovulates, half of the genetic information should end up in the first polar body. So for all the residents watching, that should be a haploid or N number of chromosomes. And then meiosis 2 will be completed after the sperm enters the egg, where another haploid or N set of chromosomes will end up in the second polar body. So what should happen can go wrong, and sometimes you can have a non-disjunction event whereby the product will have either an extra copy or missing a copy of the chromosome, so that when the sperm enters with a copy of that chromosome, you may end up with 3, like trisomy 21, or only 1, like monosomy, like Turner syndrome. And finally, this is data taken from PGT, or pre-implantation genetic testing. And it shows us what I've described already, which is that the reproductive prime in terms of egg quality appears to be in the late 20s, where about 20% of the conceptions are going to be aneuploid. By the time you're 35, it's about 35%. And then by the time you're 40, 41, it's about 70%. So just again, pointing out that in the late 30s, there is a steep drop in egg quality owing to about 50% more aneuploidy. So how do we freeze eggs? What does the technology look like? The first step is gonadotropin injections. That would be recombinant FSH, and it comes in a preloaded pen that you can see there. We also use an antagonist medication that blocks the pituitary from releasing the LH hormones so that the eggs don't ovulate and end up in the pelvis before we can collect them. Your patients will need to come for ultrasound monitoring, and we do that at 7:30 in the morning with the idea that women need to get to work afterwards. This is an example of an ultrasound with about 5 large follicles growing, and we would measure those, and when they get to a certain size, we think they're ready for egg retrieval. And the actual egg retrieval itself is a minimally invasive procedure where we use a transvaginal ultrasound, and the needle goes through the top of the vagina into the ovary, and we suction out the fluid, and then the embryologists find the eggs. So this is an example of what the eggs would look like at the time of freezing. These 6 eggs are all mature, and we can tell that because they have extruded the first polar body. So we can see that just underneath the shell or zona pellucida of the egg. But it is really important to handle eggs with care. Eggs are unique cells. They are the largest cell in the human body, and they're spherical, meaning that they have a high water content compared to the surface area. So it is relatively difficult to permeate the large water content with cryoprotectants because there's not as much surface area to get it through. The water content also makes the eggs prone to ice crystal formation. And this is just demonstrating here that at the time we freeze the eggs, the meiotic spindle is splayed out. And this makes the meiotic spindle very fragile and vulnerable to, say, ice crystals or any other type of damage, of which there are different names, that could damage the egg and render it irreversibly unusable. So fortunately, because of that change in Italian law, they needed to freeze eggs instead of embryos for religious reasons, and a new way of freezing eggs was pioneered called vitrification, otherwise known as flash freezing. And this translates into a very rapid cooling of the eggs using a high concentration of cryoprotectants to achieve an ice-free, glass-like solidification. It has resulted in much better pregnancy rates and survival of the eggs. And my embryology team took some images for me just so that I could share with you. This is an example of what the devices looks like, where a couple of eggs can be stored on the end of the device. And all of the manipulation through the vitrification solutions happens under high-powered magnification. So what about safety? The eggs are frozen. Your patient goes about her life, and then she comes back in the future to use these eggs. How well are they going to work, and are they safe? So this is a video of our embryologist freeing the eggs using the warming solution. And she would free the eggs from the end of the device and then transfer them for rehydration into the warming solutions. And then the next step would be fertilization. So anybody who's frozen their eggs can come back and use them with a sperm of their choice in the future. That might be donor sperm, or that might be a future partner's sperm. And all the eggs that are frozen would need to be fertilized by ICSI. So I'll just point out this sperm right here in the ICSI needle. And our embryologist would carefully puncture the eggs, suck up some of the ooplasm, and then see if you can catch the little sperm racing down the needle as the embryologist deposits it into the egg for fertilization. So some of the original data on eggs was published as early as 2007. And they were looking at case series of infants. There was one with 201 of 900 infants born from frozen eggs, and they showed no increase in congenital anomalies. Again, some more of the original data. This one looking at 804 pregnancies from frozen eggs compared to 1,000 pregnancies with fresh eggs. And they looked at perinatal outcomes and found no difference. So no difference in gestational age at delivery, preterm birth, APGAR scores, birth defects, NICU admission, or perinatal mortality. And then jumping forward to some very new data, hot off the press, published this year, the first study of its kind looking at longer term outcomes of children born with frozen eggs. These were 72 children born from frozen donor eggs compared with 41 children born with fresh donor eggs, showing no differences in the anomalies or their growth or health. Now, truly, across the world from frozen donor eggs, there have been probably millions of births by this time, but a lot of the longer term data is still forthcoming because, as we described, this is still a relatively new technology. So who can benefit from egg freezing? I'll show you some of the top shelf data. This is really one of my favorite studies. This one looked at 1,283 frozen eggs after 128 IVF cycles. And the reason I like this study is because these are autologous eggs. So these were not intended to be donor eggs. These were women who actually froze their eggs because they wanted to delay childbearing, or because on the day that they had their eggs taken out, the husband couldn't produce sperm. And what they found was that the frozen eggs compared to the fresh eggs had a similar live birth rate. And they were able to produce this graphic, which I share with all of my patients to give them an idea of how well their eggs might work for them in the future. So just to walk you through this, the blue line is the chance of having at least one child from the eggs. And you can see that across all age groups, more frozen eggs equates to a better live birth rate, but certainly younger eggs work better. The efficiency of egg freezing goes way down after age 39, 40. So for example, if the patient is 35 to 37 and she's able to freeze about 10 to 15 eggs, that would give her a 60% chance of having at least one child from those eggs. This is another prediction model using IVF data, again, showing us basically the same thing. We're always aiming, I always try to aim for like 12 to 20 eggs to achieve ideally like a 60% plus live birth rate estimate in the future. So just in summary, the cost of the egg freezing at PCRM is $7,800. Patients might expect to spend $4,000 to $6,000 on medications if they're not covered by extended insurance. And then after the first year, the storage fee is $400 a year. I will tell everybody who does egg freezing that it is safe and it is the best alternative that we have, but there is no number of eggs that we can freeze to guarantee a live birth. We can thaw the eggs, fertilize them, make embryos, and transfer those embryos into the woman until she is 50. And what this data is showing you is that the orange line is using a woman's own eggs, and you can see as she gets older, the chances of IVF success declines. The blue line is where the eggs stay the same age. So if you're using donor eggs or eggs of the same age, we can achieve very good pregnancy rates even after menopause into the 40s and up to age 50. So in conclusion, women are delaying childbearing, and community physicians are very well positioned to talk to women about the risks of delayed childbearing, which can be infertility, miscarriage, and increasing embryo aneuploidy. Egg freezing is a safe and effective option for elective fertility preservation. It's biologically optimal at 34 or lower, but it is reasonable from a cost standpoint up until age 37, even age 40. If you're interested in reading a little bit more about this, I had written a paper for the BCMJ, which is listed here. I'm sure if you just Google it or look on BCMJ, more details would be there. And I just want to say personally, thank you to everyone for attending our 5th annual symposium. So I will do some questions. I believe I have about three to 5 minutes for questions. So let's just see here. If patients want to predict if their fertility is waning, is it appropriate to order AMH or day 3 FSH? So great question. Day 3 FSH is a really basic test. And usually by the time it's gone up, you've missed the boat.